Hello, can you hear me? I
Yes,
can
ma'am.
hear
Good
you.
afternoon.
Now I can hear you.
Okay, welcome all. We'll just wait for 5 more minutes because some people are having some technical issues. So we'll just wait for everybody to settle down.
Oh,
There seem to be three Ronit Patils and four Ronit Patils in the
Ma'am, yes, that's because the link has been made by the IT person. So by default,
Okay,
the name is coming as Ronit Patil. So
then
I
that is why I'm
request
wondering.
everybody, yes, I request everybody to please change the name. You get this option on the side, those small three dots. If you just click on it, there's a drop down. It says rename or change the name. So you can change the name to your own name that way.
Yeah.
Poonam, is the voice audible?
Yes, ma'am, we can hear you.
Good afternoon, Anjali ma'am. How are you?
Good afternoon. Good to see you too.
Hi, Rachna. Isha.
Good to see you.
good afternoon,
Good
everyone.
afternoon. Yeah, good afternoon, ma'am.
Hetal, try. I think you will have to rename. तेरा ना by default Ronit Patil आया है. So if you can possible, just rename yourself. तो
Rename.
हाँ, participants में जा, list of participants में highlight your जहाँ पे तेरे नाम के ब्रैकेट में मी होगा, that will be you. Okay,
अच्छा,
there are many people with Ronit Patils, but yours will be Ronit Patil bracket में me. So when you put your cursor on that, you will see on the right hand corner there are three dots. So if you click on that dot, there'll be a drop down menu जिसमें नीचे लिखा है rename. So click on it and rename your वो रोनित पाटिल को फिर तो हेतल मिस्त्री कर दे. All of
हाँ,
us are
sorry.
having this.
I will
All of
do it.
us
I
are
will do
having.
it for ma'am.
Okay, okay.
I am doing it.
Okay.
So there are many Ronit Patils, which have, if you see through the scroll through the list, na, so
Done.
this, yeah, very good.
Yeah, that's what I was searching my name.
This meeting is getting live streamed, so you can also watch it on YouTube on our channel SOCVPR. Whoever cannot join, whoever's friends, colleagues cannot join, you can ask them to view this on the YouTube.
A very warm welcome to all of you for this first PG case presentation of this year by SOCVPR. I would like to invite our secretary, Dr. Manisha Hinduja, to introduce and talk a little about SOCVPR. Manisha, over to you.
A very good afternoon, and thank you everyone to join, especially our judges for the case presentation. To remove time on a Sunday afternoon, it's so difficult. We get only one Sunday off. So thank you so much everyone to join us on a Sunday afternoon for this series. I would brief you all up a little bit about the society. The Society of Cardiovascular and Pulmonary Rehabilitation. It's been established since 2 years now, and it's registered under the Charity Commissioner. Our mission is to promote health and reduce health burden of cardiovascular and pulmonary diseases. Our aim is to promote sense of fraternity amongst members of different disciplines working towards a common goal. That's improving health, experience, and care. To provide sustainable cardiovascular and respiratory care aimed to enhance functioning and to reduce mortality and morbidity and disease prevention. So how is the society going to benefit you all? There's increased networking. We can meet colleagues since it's only a specialization society. Only cardiorespiratory and pulmonary therapists have joined the society. So it will help you to improve network. It will connect and collaborate with peers and seniors. Improve your careers. Lot of information about different career opportunities are also provided. We also have different modules on pulmonary rehabilitation and cardiac rehabilitation getting conducted. So improvising your knowledge, research and educational presentations, professional affiliation, adding more wastage to your resume. So I would like to tell you all that we have affiliated with the ICCPR, and we are also helping you all to get the discounts on the course of cardiac rehabilitation. We are affiliated with different centers like Pratibha Prabhakar Pulmonary Rehabilitation Center. We are conducting different workshops, getting associated with different centers. Last year, our GB meet was held at Hiranandani Hospital. And this year also, we are going to collaborate with the multi-speciality hospital. Solidarity as a team to work for upliftment of cardiovascular and pulmonary physiotherapy and certification. Scope for patients, we are also collaborating with a lot of patient support groups. We have collaborated with the pulmonary hypertension patient support group. We are providing a database of the physiotherapists to the support group so that if any patients living in any corner of India requires a cardiopulmonary therapist for rehabilitation, they can connect through the database provided to them. We are collaborating, and it's going to be on our website soon, with the Heart Foundation, which is a support group for the cardiac patients post angioplasties and CABGs. Our members, Dr. Maria is our president, Dr. Sudeep Kale is vice president, Purvi is our treasurer, me secretary, and Poonam joint secretary. And you can also see the executive committee members. We are establishing a pan-India society. So we have Dr. Anjali, who is the judge for today from the Gujarat division. We have Dr. Narsimhan from the South division. We have Dr. Asavri from the Pune division. These are the details to join the society. You can check for our joining forms on our website, socvpr.com. It's also available on our Insta account, Society of CVPR. In case you have any queries, you can mail us on cvprsociety@gmail.com. Thank you. One facility which we are providing only to the life members is the mapping of your clinics or the hospitals where you're working, so that if any patient visits our website, they can find out the therapist near you. So this is a sample of the mapping of your location on the website. Our first conference was held last year in 2023, that is 9th and 10th December, and we would bring such more conferences soon. Thank you for your support, and we look forward to more memberships. So Dr. Poonam, who's the Joint Secretary, would now continue with our today's case presentation. Thank you.
Thank you, Manisha. I would now like to ask Dr. Rachna ma'am to please introduce our judges for today's session. Ma'am, I'll share the PPT for you.
Thank you, Poonam, for giving this opportunity to introduce our esteemed judges. And it's an honor to have all three of them here, and they are so nice and so generous to be able to join us today on one Sunday, as Manisha rightly said. But unfortunately, it's just that one day, Sunday, that there are no appointments, so people many times are available on this day. I'd like to introduce our first judge, Dr. Anjali Bhise ma'am. She is the principal of GCS College of Physiotherapy, Ahmedabad. She has done her bachelor's from MSU University, Baroda, and her master's in cardiopulmonary specialty from CCS University, Meerut. She has been awarded her PhD from Gujarat University. She has more than 35 years clinical experience and nearly 30 years of teaching in Government Physiotherapy School in Ahmedabad. She has more than 45 publications in peer-reviewed journals, and she's extremely interested in fitness and health promotion to prevent lifestyle diseases. I welcome you, madam.
Thank you so much.
My next judge is Dr. Hetal Mistry. She is an assistant professor in Physiotherapy School and Center, TN Medical College. She has more than 23 years of clinical experience and 18 years of teaching experience. She has more than 25 publications, in both national and international peer-reviewed journals. She was the recipient of the ISSN Award for the Best International Publication and Research in 2022. She was one of the members of the MEHS Syllabus Reformation Committee 2023. She has a certification in lymphadenopathy management from Tata Memorial Hospital, Mumbai. And her areas of interest besides cardiorespiratory physiotherapy is breast cancer rehabilitation and lymphedema management. I welcome you, Hetal. Our last judge is Dr. Anupreeta Thakur. She is a professor and head of Department of Cardiovascular and Respiratory Physiotherapy, School of Physiotherapy, D.Y. Patil, deemed to be University, Navi Mumbai. She has a diploma. She's completed her bachelor's from GS Medical College in 1999, and she completed her post-graduation from TN Medical College in 2001. She has a diploma in yogic education from Yoga Vidya Niketan Vashi in 2009, a PG diploma in sports training and therapy in 2010 from Vinayak University. She completed her PhD in 2016 from D.Y. Patil University. She has more than 22 years of teaching, 14 years of PG teaching, and 5 years of PhD guidance. She has won the Best Poster Award at the 5th Annual Asia Pacific Conference on Early Mobilization and Rehab in the ICU, held on 23rd and 24th August 2019 in Malaysia. She has 16 publications in national and international journals with more than 100 citations, and she has written 2 book chapters. I welcome you, Anupreeta. So I also would like to thank all three of you to give us your precious time on one day and to be here and to guide our students. Thank you, ma'am.
It is a pleasure.
Thank you,
Poonam.
Rachna.
Yeah. Poonam, on back to you.
Thank you, ma'am, and thank you to all our judges. Now, without further ado, we are going to start with the case presentation, which will be done by Aishwarya Dev, who is the final year MPT student of Cardiovascular and Respiratory Sciences from Sunandan Devetia School of Science, NMIS, Mumbai. Aishwarya, you can start.
Yes, ma'am.
So, ma'am, she'll be presenting the case. She has a PPT to, with her case presentation, and you can, if you want to ask her questions after every section, you can stop her, and we can take questions then, or we can do the questions at the end, whatever our judges wish to do.
Can I start?
Yes, Aishwarya.
Okay. So my case for today is aortic dissection with ascending aorta replacement and hemiarch reconstruction under deep hypothermic circulatory arrest. So patient Mr. Bachchan Mohante is a 28-year-old male engineer who works mostly sitting job, who resides in Odisha and is a right-handed dominant. He was admitted to the Nanavati Super Speciality Hospital on 1st of June, while the surgery took place on 3rd of June, and the date of assessment was 8th of June, which is the post-operative day 5. So the patient currently complains of pain over the suture site, over the bandaged area since 5 days, which is intermittent, increases in coughing and supine to sit activities. So on the rest, the NPRS was 2/10 and on activity was 5/10. History of present illness. Patient was apparently all right till February of 2024 when he had to undergo biannual health checkup for his office, where a 2D echo was performed which showed a mild aorta dilated, measuring a 4.3 centimeter aorta with a turbulent flow, trivial mitral and tricuspid regurgitation, and a congenital bicuspid aortic valve. Patient was asked to follow up with a cardiologist who suggested him to get a CT aortogram, which showed that the aortic cusps were normal. However, a fusiform dilatation of the ascending aorta was seen distal to the aortic root till the ascending aorta for a length of 7 centimeters, just proximal to the right subclavian artery origin. Patient was then diagnosed with an ascending aorta aneurysm with a bicuspid aortic valve. He was, however, asked to wait for surgery since he was asymptomatic, but was asked to keep a check if he felt any symptoms of any breathlessness or palpitations, while he was put on medications, which was taprosulip, which is a cholesterol-lowering medication, Tapcorbis, which is a Tapcorbis, which is a beta blocker, and Taptozar, which was to treat high blood pressure and heart failure. He continued his daily activities, which included going and coming back from his job, playing cricket almost 5 times a week and swimming twice without any symptoms, till mid of March when patients started experiencing atypical chest pain, which was the pain which started from the back, which radiating to the chest and the left shoulder, which continued for about 15-20 minutes of bouts. Intermittent patient then started having intermittently similar complaints 1 to 2 times a week. When he went for the next medical checkup, he informed the primary doctor, who again suggested a close symptom monitoring and the frequency monitoring, but again suggested against early surgery. By the end of March, the patient took a second opinion under Dr. Vishal Khullar, who was a cardiothoracic surgeon at NSSH. And he visited him on the OPD, where again an aortogram was performed, where he showed a type 2 aortic dissection, which is just the involvement of the ascending aorta without any rupture. Dr. Khullar suggested an elective surgery for the same, which was the ascending aorta replacement with the hemiarch reconstruction. The patient was admitted for the same on 1st of June 2024 in the evening and was in normal rooms with stable vitals. Again. So on 2nd of June, the medications followed were Biscodile, which is a laxative, Muciprocin, which is an antibiotic, Targocid, which is antibacterial, Tazact, again antibiotic, Pan is a proton pump inhibitor, IV fluids, DNS was given, and budesonide and Duolin, which is a corticosteroid and a bronchodilator, was given. On 3rd of June, that is the next day, the patient was taken to the OT at around 9 a.m. with an insertion of an IV insertion of an angiocath, Foley's, Riles, right femoral and radial line, right central line, which was of 4 lumens. General anesthesia was given at around 9:20 using rocornium, which is a benzodiazepine, which is a depolarizing neuromuscular blocker, Midas, which is a benzodiazepine, and fentanyl, which is an opioid analgesic. Patient was intubated using an ET tube with PRVC mode of ventilation with FiO2 of 50%, PEEP of 5 centimeters of H2O, and the incision was taken at 10:30. So the right axillary artery was cannulated, followed by which a selective antegrade cerebral perfusion was set up, and the circulatory arrest time was about 26 minutes. Median sternotomy was done. The pericardium was opened. The findings were confirmed. Right axillary artery was dissected, exposed, and heparinized. An 8 mm interguard graft was sewn to the right axillary artery with a 3O-chlorine stitch to connect the CPB circuit. Ascending aorta was excised to the sinotubular junction up to the innominate artery, and the temperature was cooled down to 20 degrees Celsius. Just a second. Hemiarch reconstruction using selective antegrade cerebral perfusion was done using a 28 mm interguard graft, which was sewn using a Prolene stitch. Rewarming was done and off bypass was uneventful. Protamine was given and hemostasis was achieved. Patient's right axillary artery was then decannulated. Mediastinal, which is 2 mediastinal retrosternal drains and 1 retrocardial drain was inserted, and pericardium and thymus were closed over the aortic graft. Temporary pacemaker was placed on a ventricular sensing mode. Right axillary wound was closed using a JP drain insertion, and sternum was closed using sternal steel wires. Subcutaneous tissue and skin were closed. Post-surgery, 4 units of plasma RBCs, 6 units of fresh frozen plasma, 6 units of cryoprecipitate, and 1 unit of SDP were given. Counts were corrected and surgical site was closed. Patient was shifted to the medical ICU, again on PRVC mode of ventilation on an ET tube with PEEP of 6 centimeters of H2O, FiO to 50%, I/E ratio of 1:2 and rate of 18. The vitals were mostly normal except the CVP, and patient was on NTG infusion for 8 ml per hour. On 4th of June, vitals were normal. The PRBC again was transfused at 3:30 a.m. The input and output was normal. The range showed 850 ml collection and potassium correction was given. On 4th of June itself, the patient was extubated and physiotherapy was initiated on post-operative day 1. Chest radiograph showed sternal wiring with metallic clips, opacity on the left lower area, likely due to atelectasis. Tracheal tube and NG tube was in C2. The CVC was on the right side. Left chest drainage tube and mediastinal drainage tube noted. Broadened aortic arch and space was seen. In the physiotherapy, the patient was made to sit edge of bed in the morning and walking was started by the evening. The medications administered on the day was Perfaglan, which is an analgesic or antipyretic, Pantocam, which is a proton pump inhibitor, glycerine trinitrate, which is to prevent any angina, Tarbocid, which was again an antibiotic, Tazact, which was an antibiotic, calcium gluconate, which is a nutritional supplement, Foracort, which is a combination of 2, and bronchodilator and a steroid. Livolin was a bronchodilator, Cremofen, which was a laxative, A to Z tablet, and ascorbic acid were the nutritional supplements. On 5th June, the vitals were stable. The patient walked with minimal support. The drains, which is the mediastinal drains, were removed except the retrocardial drain. The pacemaker was removed on the same day. Chest radiograph showed similar findings as before, and patient was comfortable to walk 3 to 4 rounds comfortably by the evening without any support. On 6th of June, again, the patient was shifted to the wards. The retrocardial drain was removed, and the Foracort and Livolin was stopped. Beta-lock, however, was started, which is a beta blocker, Lazilactone, which is a treatment for congestive heart failure. On 7th of June, the ECG was normal. The treatment continued. The patient on this day was able to walk 6 minutes without any break. The chest radiograph should improve findings with with the broadened aortic space, presence of the sternal wires, and left lower lobe atelectasis collapse. 8th June, patient climbed a flight of stairs without any breathlessness or symptoms, and patient was discharged on the same day. Current functional status, the patient was able to walk on their own without any support and do all transitions alone except supine to sit activity, for which he used to take assistance to avoid pain. Pain history, Side was at the center of the chest wall. Side is over the sternum over the suture side. Onset was sudden. Duration is since 5 days. The type was dull aching. Aggravating factors were supine lying and sit to stand activities. Relieving factors were sitting erect, resting, walking, and propped up positioning. Diurnal variation was absent. The NPRS on rest was 2 on 10 and on activity was 5 on 10. Past medical history, the patient was a seasonal asthmatic and used to take an SOS Astelin inhaler on the exacerbations. The asthma generally increased in winters and monsoons, and he has that since the age of 12. Past family history is mother has diabetes. Personal history, diet is mixed, appetite reduced, bowel and bladder regular, sleep was regular, addiction denies, and allergy is not known. So, post-discharge, the medical medications were again lacilactone, which is treatment for congestive heart failure, paracetamol, which is the antipyretic and the analgesic, Orofer, which is the used for treatment of anemia, metoprolol, which is a selective beta-1 blocker, aspirin, which is a NSAID, Creamorphin, which is a laxative, A to Z is a nutritional supplement, and syrup Alex is a cough syrup. Environmental history. The patient stays in Odisha on the ground floor with a distance to his office being 15 minutes, which he covers using local transport of car or rickshaw available in the locality. He has his office on the second floor without a lift. Indian washroom is seen inside the house. Currently staying with a relative on a third floor with a lift and a western washroom available. Socioeconomic status, upper middle class according to Kuppuswamy scale. General assessment, the patient is conscious and oriented to time, place, and person and follows commands. Vitals taken in sitting position were normal with a heart rate about 86 beats per minute. Observation, the build was endomorphic with a BMI of 28 kgs per meter square, which is overweight according to the WHO classification. The waist-hip ratio was 1.12, which is again increased. Lines and veins were absent, but the patient used a chest binder. Postural assessment. In lateral view, the patient had protracted shoulders and forward head posture. Anterior and posterior view, there were no significant findings. Gait assessment. A patient walked with a broader base of support and a shorter step length. The speed was 0.6 meters per second and the cadence was 92 steps per minute. The thoracic examination showed bilaterally symmetrical and ellipsoidal chest with a thoraco-abdominal type of breathing, with the APs to transverse ratio being 5:6, and bilateral chest movements were equal. On palpation, the trachea was centrally placed with apex beat on the fifth intercostal space. Chest excursion was reduced in the nipple and xiphisternal level, whereas tactile vocal phreatitis was reduced over the infrascapular and the infraaxillary zones. On percussion, cardiac dullness was present over the third, fourth, and fifth intercostal space, and liver dullness over the sixth and seventh intercostal spaces on the right. On auscultation, air entry was reduced in bilateral inframammillary and infraaxillary zones, left, which is more reduced than the right. Vocal resonance reduced over the infrascapular zones posteriorly and the infraaxillary zones. And heart sounds S1, S2 were heard. Motor examination, tightness, bilateral mild TA tightness was present, left moderate and right mild hamstring tightness was present, while mild bilateral iliopsoas tightness was present. Trapezius and levator scapulae tightness were also present. Range of motion, all physiological ranges were present. So in MMT, for the upper limb, the shoulders, flexors, abductors were around 4, while the external extensors, internal rotators, external rotators were around 3+. The hip flexors were around 4, extensors, abductors around 3+, while knee extensors and ankle were 4+. Then cardiopulmonary assessment, functional capacity, 6-minute walk test. The patient walked continuously for 6 minutes without any break and covered a distance of 168.8 meters, which is around 25.69% of the expected distance to be covered. The vitals recovered by 4th minute and the patient was normotensive during the whole time. The peripheral pulses were present and the PEFR was 450 liters per minute, which is again normal. The outcome measures, the functional independence measure was around 125 on 126. The Tampa kinesiophobia questionnaire out of the 40, so scored 48 points with activity avoidance subscale on 21 and somatic focus subscale on 12. So then quality of life BREF, physical health was 69 on 100. Physiological was 69 on 100. Social relationships was 75 on 100. Environmental was 81 on 100. ICF, Mr. Bachchan Mohante is a 28-year-old male.
Aishwarya, just a moment. Yes. Ma'am, any questions you all want to do now or should we continue? Anjali, ma'am.
You can
At
continue.
the end, we'll ask. I
Okay,
think.
okay, fine. Okay, Aishwarya, you can continue.
Okay. Patient Mr. Bachchan Mohante is a 28-year-old male from Odisha who was diagnosed with a fusiform aortic dissection with a bicuspid aortic valve in February 2024, following which he experienced symptoms of back pain radiating to the chest. He underwent a hemiarch reconstruction and ascending aorta replacement on 3rd of June 2024 for the same and has been rehabilitation since then. Comorbidities, bronchial asthma since the age of 12 on SOS Astelin inhaler. Sorry. So body structures related to the cardiovascular, immunological and respiratory systems, intact other immunological systems, the chambers of the heart, arteries of the upper and the lower limb. Impaired is one, the bicuspid aortic valve. The supporting finding is the 2D echo. Clinical reasoning, bicuspid aortic valve is often an inherited autosomal dominant pattern and is associated with mutations in several genes. It occurs when the aortic valve develops only 2 cusps usually instead of 3. This abnormal development leads to various complications, which includes the aortic stenosis and regurgitation. However, the exact environmental factors that can lead are not understood. The qualifiers 3. Body structure, the impaired second one is the ascending aorta and the hemiarch of aorta. Supportive finding is the CT aortogram and the OT notes. Bicuspid aortic valve leads to an altered hemodynamic, that's a turbulent flow, and increases aortic valve stresses and aortopathy, which is degeneration of the elastic fibers, and loss of smooth muscle cells, which leads to weakened aortic valve, making it prone to dilatation and aneurysm formation. There was an aneurysm formation with a symptom onset of a type 2 aortic dissection. So basically only related to the ascending aorta. The ascending aorta was then replaced using a 28 mm interguard graft and a hemiarch was reconstructed. However, bicuspid aortic valve is often associated with some conditions like Marfan's or Ehlers-Danlos syndrome, but the investigations were not done, as well as the patient did not show any physiological symptoms of it. Impaired is third is the axillary artery. Supportive finding are the OT notes. Clinical reasoning was dissected and cannulated to establish the cardiopulmonary bypass circuit and then sutured back using a JP train. The qualifiers 1. Structures related to movement, intact are the muscles of the lower limb and the bones. Impaired is the sternum and the muscles, aponeurosis of the pectoralis major fibers. Supportive findings are again the OT notes. Clinical reasoning, incision taking during a aortic dissection and the sternotomy procedure led to the affection of sternum and aponeurosis of the pectoralis major fibers. Muscle tightness lead on examination. Due to cross alignment and shortening of the muscle fiber, there's reduced length of sarcomeres and posture again on examination. Due to muscle tightness, there is an altered length tension relationship of the muscle that leads to faulty mechanics. The pain causes the person to be in a protective form for the sutures to thereby having protracted shoulders. Skin and related structures impair the skin over the sternum. Clinical reasoning is incision taken during the surgical procedure leads to affection of the skin over the sternum. Body functions, sensory functions and pain, intact are the sensations. Impaired is the pain. Supportive finding is the pain assessment and the NPRS. Clinical reasoning, surgical incisions and tissue manipulations during sternotomy cause tissue damage leading to inflammation and activation of pain receptors or nociceptors in the surrounding. Median sternotomy also involves cutting through the sternum, which disrupts the bone cartilage and the surrounding tissue. This trauma activates the pain receptors in the periosteum and the soft surrounding tissues, contributing to the postoperative pain. Tissue injury during surgery triggers inflammatory response characterized by release of pro-inflammatory mediators like cytokinins and prostaglandins. Inflammation sensitizes the pain receptors, amplifying pain perception along with prolonging the process of healing. Chest muscles may experience strain or microtrauma during activities such as coughing, deep breathing, or movement post-operatively. This strain activates the pain receptors in the muscle fibers, causing discomfort. Functions of the cardiovascular, hematological, and the respiratory systems impairs the chest expansion and excursion. Supportive findings are on examination. Clinical reasoning, pain affects the ability to take deep breaths, leading to reduced tidal volume, and pain reduces chest wall movements and reduces lung compliance. Some patients, especially those with pre-existing lung conditions like asthma, may experience a longer recovery period. This can be due to a combination of factors such as reduced lung volume, atelectasis, and potential airway hyperreactivity post-surgery. Muscle relaxants used during surgery can result into weakness of respiratory muscles, further impacting chest expansion and excursion. And his underlying asthma could further exaggerate the findings and the respiratory condition. Structures related to neuromuscular and movement-related functions. Impaired strength, gait, and reduced functional capacity. Supportive findings is on examination. So nutrition, inadequate nutritional intake during recovery with the patient being on liquid diets for 4 days and even prior to the surgery can impair muscle protein synthesis and contribute to overall muscle weakness. Post-operative factors such as nausea, reduced appetite, and dietary restrictions may affect nutrient intake. Physiological factors like distress and anxiety related to the surgical experience or recovery process can contribute to fatigue and reduced motivation for physical activity, affecting muscle strength. Post-operative respiratory complications such as atelectasis can lead to respiratory muscle fatigue and weakness. Kinesiophobia leads to protective patterns in movement, leading to altered gait and muscles being forced to avoid pain. Activity and participation. So, in activity and participation, learning and applying knowledge, general tasks and demands, communications are intact. Mobility, walking, and sitting are the activities. Limitation is supine to sit. Capacity should be able to do it independently without pain. Performance is patient takes help from the relative to help him up. Otherwise, when he performs it independently, he experiences pain. Self-care, activities are eating and grooming. Bathing is the limitation. He should be able to do it independently. Performances requires assistance to wrap the bandage around in waterproof dressing, and then bathing is done independently. Domestic life, major life areas in community, social, and civic cannot be commented on. Contextual factors, environmental factors, product and technology, medicine, medical facilities, binders, and lift are all facilitators. Barrier is office on a second floor without a lift. Support and relationship is supportive family and caregivers. Attitude is positive towards recovery and aware, and services, systems, and policies availing. Personal factors, age. So age is a facilitator as well as a barrier. Being younger in age provides a better recovery. However, may require a resurgery or can have symptoms later. Fitness, lifestyle, and habits. The patient has an active lifestyle. Coping lifestyle is a laid-back attitude. Education is educated. Profession, sitting job, engineer. So his job is not going to be affected due to the surgery. Individual character style is type A, which is the patient is anxious. Impairments. pain, reduced lung expansion and lung capacity, reduced strength, altered gait and posture, and reduced functional capacity. The management is based on the aortic dissection activity guidelines by Northwestern Medicine, the AACVPR guidelines of cardiac rehabilitation, and the exercise and physical activity for post-aortic dissection patients from the clinical conundrum, and again activity from the circulation, again 2 different articles by Mr. Chadda et al. Patient education, reassurance and explanation about cardiac condition and procedure and treatment, addressing psychological issues like anxiety and kinesiophobia, etc. Physiotherapy interventions are shown to reduce anxiety pre and post physiotherapy, according to the article. Adherence to medication is important. Perception and management of symptoms like breathlessness and palpitations. INR precautions with avoiding any bleeding, and consulting with the cardiologist before even getting a dental procedure, a major dental procedure, which can lead to bleeding. Instruct on breathing exercises and use of inspiratory spirometer to instruct on use of breathing exercises and incentive spirometer to prevent atelectasis and improve lung function, which is crucial given his history of asthma. Avoid any sexual activity to allowing the body to heal for at least about 6 weeks post surgery. Management of modifiable risk factors, which is his class 1 obesity. The dietary guidelines given in the AACVPR suggest about fat of 25 to 30% of the total calories, with saturated fat being less than 7% of the total calories. Less than 200 mg per day cholesterol intake, and additional recommendations is including soluble fibers at 10 to 25 grams per day, and including plant stanols and sterols, which help lower the LDLs in the blood. Resumption of the physical activity. So ADL, swimming can be started around 6 weeks later, post the sutures are healed and the sternum's healed. Avoiding any contact sports, wound care and sternal precautions. Avoiding doing bilateral movements are supposed to avoid unopposed tractional forces, no pulling or pushing, no lifting objects above 5 pounds, no push up from a chair, splinted cuffing, huffing and transfers wherever there is pain, lifting light weights. So phase 1, the goal will be the patient should be able to walk 400 to 500 meters without any support, with a RPE of less than 11 and no pain in 1 to 2 times a day. Pain management is done using manual splinting or binder. It provides an extra layer of pressure to counteract any jolting. Breathing exercises are shown to reduce pain. Maintaining bronchial hygiene. So the protocols just followed in the hospital included therapeutic positioning, percussions, vibrations, breathing exercises, splinted force expiratory techniques, and early mobilization. Preventing any secondary complications like lung, any atelectasis, we're avoiding, or any post-operative anesthesia complaints, we are doing breathing exercises and active movements to avoid any DVTs. Improve lung expansion. Segmental breathing exercises, thoracic expansion, and incentive spirometer and early mobilization. Also, higher rates of deep breathing exercises, which is around 30 breaths per hour, is shown to significantly improve oxygenation in the first 2 days post cardiac surgeries as compared to 10 deep breaths per hour. Improve or maintain functional capacity using graded mobilization, where the intensity should be heart rate plus 30. So for him, it is around 116 beats per minute. RPE should be less than 11, on a 6 to 20 box scale. Frequency 2 to 3 times a day in the hospital, 3 times a day was practiced. And exercise bouts about 3 to 5 minutes around the total duration of 20 to 25 minutes. So initially active exercises were started in the bed, followed by bedside activities and gradual ambulation as tolerated by the patients thrice a minute. followed by warm up, which is again with active exercises, walking and cool down again with active range of motion exercises and breathing. Starting with 100 to 200 meters, progressing to 200 to 300 meters. Once the patient has covered around 400 to 800 meters, climbing of around 3 to 6 steps can be started, and eventually the walking distance can be increased to around 20 minutes. For phase 2, so in phase 1, again, any isometric exercises are to be avoided. In phase 2, within 8 weeks, Mr. Bachchan will be able to achieve a cadence of 105 steps per minute or a kinesiophobia score of less than 30 during supervised walking session, covering a distance of 400 to 600 meters continuously without breaks while maintaining a RPE of around 11 to 30. Exercise sessions. So this is what was suggested. Exercise sessions to be conducted in a warm environment, preferably to minimize any cold-induced bronchoconstriction. Use of his bronchodilator before exercise if needed, and carrying his rescue inhaler at all times. Monitoring respiratory distress during exercise and adjusting the activities as necessary. And weight reduction using a activity duration of a longer time. So aerobic exercises initially at 3 times a week, progressing to 5 times a week, with an intensity of 50 to 60% of them.
Stop you.
Hello.
Hello, can I stop you?
Yes, ma'am. Sure.
Patient is not in this phase right now, is he?
No.
Okay. So can you just tell me the current complaints?
So, ma'am, currently the patient just had pain over the suture side. Otherwise, his functional capacity was reduced. That is, he was going about 25% of the estimated distance in the 6-minute walk test. But since the patient stays in Odisha, we were not able to take a follow-up for the same. So this is what we had suggested him for phase 2 as such.
Okay. He had a complaint of supine to sit
Yes.
when he left the hospital?
Yes. So he was taking assistance from a family member. So even after advising him to turn to his one side sideline positions and then get up from the transfer to avoid that pain, he still, when he was doing it on his own, he had a tendency to just get up straight, and he used to ask a family member to help him for the same.
So the family member used to help him from the back or
Yes, from the back.
from the back?
Yes, with the arm behind his shoulders and pulling him up.
Okay. And what is the shoulder range? What was the shoulder range when he...
No. Shoulder range was normal. He did not have any shoulder range restriction.
It was full
Yes, ma'am.
laterally?
Yes, ma'am.
Okay.
Just one more thing. When was the 6-minute done at discharge?
Sorry?
The 6-minute
Yes, ma'am. The date of the discharge. So it was on POD. So he got discharged. The day before the discharge, it was done because the discharge intimation had already been given to the patient. So we took the 6-minute walk test, and the next day, early morning, the patient was discharged.
That was about how many days post-op?
7.
7, right? So currently he is in phase 2, right? Then that means it was on 7th or 8th of June, then I guess.
Correct. But we, as I said, we were not able to follow up with him with the phase 2 since he did not have a follow-up. He was just staying a little far away and was going to come only for the suture removal. Till the time it was the suture removal, that's the 15th day. He was going to come, and otherwise he was going to go back to his hometown.
So that I understand, but right now, today is 22nd, so it's almost 22 days post surgery.
Achha, so today, yes, he'll be, then he'll be in phase 2, sure, yes.
Yeah, that's what I think. That is what ma'am asked also, that currently if he was coming, then this is what you would be doing for him.
Yes.
Okay, continue.
Can I ask you one more?
Yes, ma'am.
You have chalked out everything about the phase 2 and all, but what you have done in phase 1 when the patient was there and his X-rays were continuously showing collapse or atelectasis or left overload. So,
ma'am, for him, we were already on as I mentioned, with bronchial hygiene therapy, percussions, vibrations. continuous left side up positioning was also encouraged for the patient, as well as the thoracic mobility and spirometer was also encouraged to be done in left-sided up position for him.
There were any ICDs and all drains
Initially,
during the discharge time or during that
no.
phase of 7 days?
Yeah, no, nothing as ICDs. He just had the retrocardiac drain and the two mediastinal drains before that.
Right. So only breathing exercise will improve that collapse. Hello.
Sorry, I didn't get your question, ma'am. Could you repeat? The voice got cracked.
So only breathing exercise will be the management for that collapsed lung?
No, ma'am. As I said, even passive positioning and percussions, vibrations from our side, along with spiro and left upper, we were started.
Okay.
Go to previous slide, Aishwarya. I think you.
So this all was already being done with sprinted FET, any percussions, vibrations, therapeutic positioning again.
Okay.
So did they take any X-ray before he was discharged?
Just before he discharged, no, this was the last X-ray that they had.
That was immediately after the surgery?
No, this was the one, 7th.
7th June. Okay.
Yes.
So they,
Yes, ma'am.
what was the chest expansion at that time?
So it was reduced. I will just give you the values. Just give me a minute.
No, it was reduced. Okay. So what
Yes,
did
ma'am.
you do for that?
So I'm again, segmental and specific breathing exercises were started for the same. At each level, we were doing it for him.
Sorry for intervening. Our participants can ask questions.
We'll allow the participants to ask questions at the end once.
Okay.
Yes.
Okay. Actually, in chest X-ray, if you see, there is something we are missing out. I feel the patient might be having left ventricular hypertrophy. It's not about majorly collapse. Even you can see that left ventricle, it's extending to the lateral costal margin, if you see. And there is a huge bowel gas under your under your diaphragm, the left under diaphragm. So even that sometimes mimics your lung collapse. So you should be very certain whether the collapse is happening on anteriorly or laterally or posteriorly. You should be clearly doing that by doing auscultation. And later there are many causes for your chest collapse too. So if you have seen these things, maybe some collection might be there, or it might be mucus plugs. So based upon your assessment only, you can come out what might be the reason for that collapse. I feel, but this X-ray is clearly showing that it's a left ventricular hypertrophy. You can clearly see. Can you see? Have you seen in echo? Is there anything like that, or any mentioning of left ventricular hypertrophy, ma'am?
Initially, pre-surgery, they had not mentioned anything, but post-surgery, there was no echo done for a follow-up.
Okay, fine. Thank you.
Can I continue?
Can continue or
When he was discharged,
Yes.
what exercises did you prescribe?
So for now, initially, we actually calculated around so from his 6-minute walk test, we calculated a roughly estimate around for a 20-minute distance and asked him to at least complete a 20-minute distance initially walking. And since he did not, and stair climbing was advised initially, since he was helping, so since he was in pain.
Walking continuously?
Sorry? No, intermittent pain, but since the what do you call, the compliance to in the hospital post he was shifted to the wards was a little reduced. So that could also be one of the contributor to the functional capacity, if you want to call it. So we had suggested him walking and stair climbing initially, and later I suggested him like on a prolonged basis. Again, since his office is around 15 minutes away, he can continue after 6 weeks. He can continue with the swimming that he was doing, going and coming to the office on the bicycles, and everything on a long-term basis can be done.
Was he involved in swimming before? Because I don't think
Yes,
you
ma'am.
mentioned that anywhere.
Yes, ma'am. No, I have mentioned it, ma'am. Swimming, and he was playing cricket also.
So what about cricket? If he wants to play cricket in future, do you advise him?
No, ma'am. Again, initially, no. Since it's a contact sport, you do not want to avoid any injuries to the patient. So anything like a single tennis or anything which is not a immediate contact sport, or badminton can be suggested in replacement for it. But cricket, football, no.
Even badminton, you can suggest?
6
Ma'am,
weeks.
post the sternum is healed, yes, we can suggest.
So
But again, the
how long-
intensity,
How long
How
does
much
it take for the sternum to heal?
it takes around 6 to 8 weeks, ma'am.
Okay. And what about stair climbing? When you will prescribe stair climbing?
Ma'am, the stair climbing was done on the day of the discharge as well. The patient was comfortable to climb one flight of stairs.
Patient will be comfortable, but according to the ideal, your guidelines, in
Yes.
aortic dissection, especially in aortic dissections.
So, ma'am, in aortic dissection, as such as I mentioned, the two guidelines, they do not give any evidence to as well. Stair climbing can be started, but according to the ASCVPR guidelines, it says after the patient has walked around 400 to 800 meters, we can start with around 3 to 6 steps initially, and then follow up with the more.
Your patient falls into which type of aortic dissection?
Type 2, which is only restricted to the ascending aorta.
Okay, which is more dangerous? Type 2 or type 3 or 4?
Hello?
Hello, which is more complicated, dangerous, type 2, 3 or 4?
I will have to get back about it, but it's mostly type 4 where the ascending aorta as well as the arch is involved.
So what are the complications followed by this aortic dissection? According to considering his age, his occupation, and his comorbid factors.
So, ma'am, again, when we speak about complications as such, the type of since the bicuspid valve here is still remaining, they haven't changed the bicuspid valve. There's a chance of reoccurrence for the same, since for the classification. So the aneurysm can occur again, because even after the ascending aorta that is being replaced, the bicuspid aortic valve, which is actually causing the turbulent flow, is still in place.
What is the lifestyle modification you will give, advice you will give to the patient?
So for now, again, avoiding any addictions like smoking and
He is not doing it. You said, no?
yes.
In history, it is not there.
So
What
again,
are the other chances which you have to avoid in life, in his life?
okay, so ma'am, again, as I mentioned, having a healthy diet, he has a little high cholesterol and weight management, which is important for him. Maintaining a good oral hygiene, because gum diseases are known to again affect the heart valves. With already bicuspid aortic valve, even though now it's coapting properly, it can be later on that it gets diseased, they may not coapt properly. Again, regular doctor's visit and cardiovascular for monitoring, consistent exercise and healthy weight, continuing with the medications and continuous BP monitoring, as again higher BP can cause a turbulent heart flow.
Right. So BP monitoring is very important.
Yes, but even
Because
with
there can be chances of reoccurrence.
even both hand, the BP should be measured, as sometimes in aortic dissection, the BP on both hands come different. So it has to be measured from both hands.
What could be the signs and symptoms of recurrence, which patient should be educated priorly?
Ma'am, again, similar back pain, which is sometimes radiating to chest veins, it's sometimes not. Palpitations and severe breathlessness can be one. Two complications is the patient can be easily notice to get around.
Okay. Yeah.
What do the guidelines say about the intensity of exercise?
Ma'am, intensity of the exercise specific for aortic.
And
Huh,
how
so-
do you prescribe it?
So again, intensity of the exercise can be around. So this is phase 3. Sorry, this is phase 2. Initially can be around 50 to 60% of the heart rate. So for the patient at home where he is in Odisha, where if he is not able to measure his heart rate on its own, even after teaching him,
Patient on beta blockers?
yes, this is the beta blocker adapted formula which is used to calculate it. Just
This is a beta blocker adapted formula.
yes, ma'am.
Then how will he know that it is 50 to 60% of maximum
So,
heart?
ma'am, again, as I said, if the patient is not able to measure his heart rate on your own, the patient had an SpO2 monitor. But if that is not possible for the patient to even, carry on all the times when he is exercising, since it's very uncomfortable, the RP or the box scale printout that can be kept, and the patient can be asked to monitor his or own fatigue levels. So if it goes anywhere beyond 13, the patient can be asked to take a break and then continue with the exercises once the RP is low.
Why have you set the goal as 400 to 800 meters? Is there any specific reason you've given that range as?
So no, ma'am. According to almost the 20-minute walk test distance, what we calculate, so around in 6 minutes, if he's walking that much, the patient is generally encouraged to walk around 20 to 30 minutes on his own. So initially for 20 minutes to that range is approximately 400 to 800 meters according to them.
That is the normal range, I suppose, right?
Yes, ma'am.
Do you think ideally he should take a graded test before going for the next phase of rehab?
Yes,
Hello?
ma'am. Again,
Ma'am. Yes. Have you put your goal, one of the goal, how you will treat this patient, or how you'll follow up?
so, ma'am, again, for me to follow up, one thing could be the telerehabilitation that we will have to do. But initially, it is better if the patient has any physiotherapist in his locality, it is better to go on one-to-one basis and have the rehabilitation setting done.
So you cannot do it one-to-one by tele-rehabilitation.
Ma'am, telerehabilitation can be done, but the better monitoring of heart rate and the rest the symptoms is done when the patient is there. If the patient's heart rate suddenly spikes or BP suddenly shoots up, there should be someone around him initially, at least I believe, that the patient should be able to reach out to, since his cardiologist is also out of town.
Aishwarya, since what is the socioeconomic status of the patient?
Upper middle class.
Middle class. So can we suggest to use a heart rate monitor in that case if he can afford? Because I guess that should be affording, and that will be a better guide for him to monitor his heart rate, even if he cannot measure it on his own.
Correct.
We can try to use more technology in this case, because RP finally becomes very subjective, right? So I may feel it is 13, but I may still overexert because I may be enthusiastic. So of course,
Correct.
RP is a good option, no doubt about it. But since the patient is affording, of course, he can go with a heart rate monitor, which can monitor the heart rate, and probably because heart rate in this case will be a better indicator than other parameter to control his intensity.
Yes, ma'am. I will keep that in mind from next time.
What are you going to do about his kinesiophobia?
So again, for that counseling, and once his anxiety reduces, and even post suture removal, after sometimes the kinesiophobia score might come down on its own, as well as the patient more he is encouraged to do the activities, and once he learns that those activities are not going to cause him any harm, the kinesiophobia will come down on its own. That is why even in goals that I've mentioned, cadence is also one of the indicators. If the patient is walking slower due to the phobia or anything, that is also for us without taking the score is a good indicator to just keep in mind if the patient's speed is increasing while walking or even the cadence is improving.
How much is the score just now? When he left, how much was the score?
So when he left,
When can you say it is not kinesiophobia? And
it's if below 17, we do not say the patient has a kinesiophobia. The patient score was 48 on a 68 scale.
so it was on the higher side, right?
Yes.
So what will you do for that?
Ma'am, again, patient education that doing the movements that we are doing will not affect him or alter his health can be done. And again, doing activities that reduce the pain will also help him to reduce the kinesiophobia, since pain is also one of the limiting factors to it.
What sternal precautions are you going to have you taught him already?
So ma'am, again, no pushing, pulling, no lifting heavier objects. So normal objects initially, so once he's going into phase 2, normal objects can be started like a bottle of water, again half filled. No push up from a stair, again to avoid pain, splinted, huffing, coughing and transfers. And lifting only light weights, which is less than 5 pounds initially.
Are there any guidelines, specific guidelines for sternal precautions?
And the article, okay, there is EVPR, but this article that is mentioned in 2010, I've quoted the article below in the slide, shows that these guidelines are there.
Have you heard of the term move in the tube?
Yes, ma'am. But currently, even with move in the tube, we are allowing there is no restriction over the overhead activity that we follow in the inpatient setup of our department as well. So move in the tube suggests the arms being kept close to the body and elbow being flexed even when we are trying to, lift the activity hands overhead. But here we were doing all the activities on a longer this thing.
Bilateral activities you did?
Yes, ma'am.
Okay. When you turn and when you try to sit up, right?
Yes, ma'am.
In bed, from supine, you go to you turn and then you sit up.
Sorry.
If you push with your hand, is it allowed?
No. Sorry?
From supine when you turn. Huh? I'm talking
Yeah.
about phase 1, right? Only
Yes.
phase. When you from supine when you turn,
Yes.
you want to get up. Okay, you turn to one side and then you push with your hand and then you get up. Okay, you wanted him to do that, right?
No, ma'am. No. From the yes, but even when you're doing it from the chair, you have to bear the weight of the whole upper trunk. While you're doing it from the bed, the waist as well as the legs actually bear some weight. Once the legs are propped down, it is easier to get up on a bed than from a chair because pulling up, as it is lesser forces when you compare it. And even though, even if initially the relatives are helping him with the same, this is a less strenuous transition than getting up straight from the bed.
We can have questions from the audience, huh?
At the same moment, what the madam is asking, can you advise some energy conservative techniques?
Sorry, ma'am. Could you repeat the question?
Whatever the ma'am said about supine to sitting position and sitting to standing and all, can you describe some energy conservative techniques?
Okay,
Can you describe?
Okay, so initially for energy conservation, again, taking initially is pacing the activities, what we say, positioning. So if the patient, the 5 P's which we say, the positioning.
Can't hear you properly.
Okay, just give me a minute, I think.
Hello, can't hear you properly.
Just a minute. Hello.
Yes, Aishwarya, you are audible.
Okay. So
Yeah, now I
the
can
five
hear you.
P's of the 5 P's of energy conservation are positioning. So if the patient has any dyspnea, once the position is changed, the patient can use a
Yeah, I can hear you. Can you hear me?
Yes, ma'am. Hello. Am I not audible?
You are audible.
Can you
Aishwarya.
prescribe energy conservative?
Hello.
Yes, Aishwarya.
Yes.
You
So
can
the
continue.
Continue.
So the 5 P's of energy conservation is following his position. One is once the patient sits up, he can just recline a little using a pillow. Then second is pursed breathing. Then pacing, and again prioritizing that can those activities be are really necessary for him to do at that kind of time, and planning the activities before initially starting, so there is a tone to it and a flow to it, and there is no extra and unnecessary movements done which help to that will help to conserve the energy.
Secondly, you said that your patient was there for 7 days, right?
Yes, ma'am.
Hello? Yeah, your patient was there for 7 days, right?
Yes, ma'am. 8 days, so he was discharged on the 8th day.
That was
Ma'am, I'm sorry, but your voice is
phase
cutting. I'm
1.
not able to hear you.
Do you really advise mediastinum sutures are there, drains are there, pain is there? Hello? Can you
Hello.
hear me?
Yes.
Is it advisable to give percussion vibration in the
Yes, ma'am.
first phase of
Yes, even despite of the pain, the post-operative, that is the effect of anesthesia, can lead to different effects, like even the chronic nerve activity slow down, where tidal volumes are lesser, where there's lesser chance of atelectasis, which is post-operative pulmonary complications rate is higher. So even there's those percussions and vibrations given in the
but
position.
your patient was having
Sternotomy.
Sorry.
but your patient was already having pulmonary complication, no? On X-ray.
Yes, ma'am, but
Hello.
yes, but even despite that, there could have been an increased in pulmonary complications despite of that. So the percussions, vibrations, even despite pain, can be initially of a little milder intensity, but will help to with other complications as well. And helping to clear the secretions will also help to keep the lungs more efficient.
For how long is he supposed to put on the binder?
So, again, for the binder, there is no specific guideline, but till at least the suture, post 2 weeks, the suture removal is suggested by the Northwestern guidelines for the aortic dissection.
Does the binder cause any restriction in chest expansion?
Yes, ma'am. Yes.
Does cause?
Yes. Sorry?
Does it cause any chest restriction?
Yes, ma'am. While even we are doing segmental breathing exercises, the movement itself, the mechanical movement of the chest itself is restricted when you put a binder on.
So how do you put on a binder? How do you teach the patient to put on the binder?
So initially, when breathing exercises, the binder which is put on is a little loose that will allow the chest to expand properly. And otherwise, during transitions and the patient is asked to put on the binder where the extra cushion side is placed directly over the suture pain area, and the patient is not excessively tight, but just firmly over the chest.
No, do you fully expand the chest and then put on the binder, or just depending?
You take a deep breath in. So the patient is asked to take a deep breath in, then the binder is put on, and then the patient is asked to normally breathe in.
That is how it is done, no? So
Yes, ma'am.
ideally, there should be no restriction with the binder.
Yes, ma'am, but that is the normal breathing rate. So when we are actually focusing on segmental breathing and thoracic expansion exercises, we are actually even with when you're doing breath holds, we are even improving the lung expansion, opening the collaterals in those times, which helps to lung to expand more. So even with the completely breathing in, the patient might still have some restriction to the complete breathing.
I'm not able to understand you. Can you explain it again?
Okay, so even after the complete breath-in, which is normally done in the resting position by the patient, when we are putting the belt on, when we are focusing on specific breathing exercises, maybe segmental or even where you're doing a breath holds, the patient, there is an increased expansion of the lungs where we are opening the collateral ventilation pathways and we are focusing on increased expansion than normal. That might, so when we are putting on a deep, even after a deep breath, there might be still some restriction to breathing exercises when we are performing.
So you keep the binder on when you're giving him patient breathing exercises?
Sorry?
The binder is there when you're teaching the patient breathing exercises
Yes.
all the time?
So we generally put it a little loose initially. So while you're doing a breathing exercises, and again, once the patient is doing the transitions, we put it on a little tighter. Firm.
Okay, what is the difference? I mean, the cardiac rehab following CABG, not this aortic dissection. How is it different from other cardiac surgeries?
So in
Special
cardiac,
care, do you think you need to take in these patients?
sorry?
Any special care or any special monitoring is required?
So again, as I said, when we are doing a CABG, it's more about the coronaries and the heart that is less perfused. When it's the aorta, it's the vessels that is circulating throughout it's the blood throughout the body. So there can be any the complications can be either ways. But when you're doing for a CABG, again, when we're doing a BP monitoring, the symptoms that are seen can also be majorly related to the chest or chest pain, while aortic dissection, as I mentioned, it can be back radiating to chest. So the patient has to keep in mind about that. Again, with aortic dissection, initially it's not very quickly, again, like CABG, it's not initially quickly diagnosed because the false lumen again re-enters into the main vessel. And then, yeah, yes, ma'am.
In the third phase of rehab, do you think should be, you said lifestyle change is necessary. So
Yes,
you
ma'am.
need to advise him for physical activity, lot of physical activity now?
Ma'am, he can not excessive activity, but he can try and go back. Since he's only 28, we can try and make him go back to the activities that he was doing before. Again,
Yes.
except for the
No, but as prescribed exercise.
as a prescribed exercise, he can start with initially circuit training where you're doing a low intensity followed by a high intensity followed by a low intensity as it is suggested. Again, stationary cycling and walking can be done. If stationary cycle is not available, you can just do a bicycle, which is initially generally very slow cycling. So
You have not put any photographs of the patient. Was it not allowed?
Yes, ma'am, for confidentiality purpose. So we have taken consent for name being used, but pictures we were not allowed to.
Even with the face covered?
Yes, the patient was not comfortable with photos being taken, but he was okay otherwise, like he was cooperating, but he didn't allow for photos. And since we are in a private this thing, we didn't even force him to. We asked him once, but then he said,
When you look at the patient, na, you get a
yes,
better understanding of the case.
yes,
That is.
we.
Mhm. You can ask.
But here you have mentioned 50 to 60% maximum heart rate. Somewhere just now you mentioned target heart rate as well. So you were
No, so
talking
I'm
about the
sorry.
same.
No, that is a mistake from my side. I've used the target heart rate formula with like so 164 minus 0.78 this thing for this thing, the beta blocker formula.
Is it a reliable formula?
For the beta blocker formula?
Yes.
Yes, it's the reference is from, actually it's given in one of the books for the cardiac rehabilitation only. I will have to search for the book.
I think they are still working on it, I think. Is there a reference there?
Ma'am, there is a book of cardiac rehabilitation which gives the formula.
Who's the author of the book?
Just give me a minute. I actually haven't put it in the slide. I will have to search for it. It's there in my Google Drive.
Madam, you can also ask something. Rachana madam.
हाँ मैम, आप लोग कितने अच्छे पूछ रहे हो.
Yeah.
I also had that query of the photographs, but then again, so when you're, it's all, since patient is from a private hospital, it's a different thing altogether.
Yeah, understood. No, but when you have a picture of the patient, no?
Yeah, it speaks volumes. It tells you anything about the patient.
Exactly.
The book is Joseph Nabor, Cardiac Rehabilitation Manual.
Okay. Okay.
Was that formula validated?
Sorry?
Is that beta blocker usage target heart rate formula is validated? I mean, was it utilized, and is it validated in terms of utilization?
I actually haven't found any articles related to the validation. I found it in the book and I have used it. I will have to get back to you on that. I'm so sorry.
Usually we in our hospital, we used to work on the patients with aortic dissection based on RP. RP is the best one because with patients on beta blockers, they tend to have this blunted response. It's best to use RPE only to what we have seen. We use that.
Better to use
So,
that.
do you think what might be the risk factors for this patient to develop this kind of aortic aneurysm? What predisposing factors the patient exhibited to present with this aortic dissection? So from the assessment or from the point of the patients, what are the things or what are the factors?
So the patient already had a bicuspid aortic valve which was detected, post which he had the aortic dissection. Otherwise, he was asymptomatic till the age of 28. It was recently in February when he was diagnosed with bicuspid aortic valve. In March, he started developing symptoms for the same.
Is there any positive family history of?
No, there is no familial history. Yes, no.
You said
Not that it was tested, but they anyways say that 2% of the normal population is with the bicuspid aortic valve. So the family history in them, no symptomatic history or any surgical history present. But if there is any, then it's not detected yet.
So he had aneurysm, right?
Yes, it was not ruptured.
It's not ruptured. Okay. He's obese, right?
Yeah. Yes.
What was his BMI?
I will have to check. Just give me a minute.
28, you said, no?
28 point something.
Okay. Can this be a reason for any aneurysm? Basically, it should be a risk factor.
It is a risk factor as such. He's obese. That is known. His waist ratio is also increased. But again, that increased BMI was present earlier as well, right? So
Okay. I mean, the one reason what we see is plague, which is a common reason to develop aneurysm in any vessel. If you see,
Is
even
the accumulation.
yeah, of course. And one more thing is vitamin D deficiency. They say the endothelial dysfunction is one other reason that causes. I mean, the reason, the risk factors are much. And he's not a smoker, right?
No, he's not a smoker.
Okay, fine.
So,
Thank you.
you should promote physical activity because it improves the endothelial function. It is very important that you put him, encourage physical activity now.
Yes, ma'am.
And prescribe activity for him.
Yes, ma'am.
It is not just that he goes back to his sports and things like that. No, it should be a monitored thing.
Monitored program, 3 to 5 days times a week, at least 40 to 45 minutes.
Intensity exercise, yes, necessary.
So again, moderate. Ma'am, here again, there was a contrasting evidence where it had also shown that moderate. Just a second, I'm just finding where I put the article.
Anything significantly pre-operative EF and post-operative EF, any significant changes
So,
you have
as I said, the post-operative, there was no, what do you call, the echo, that was not done again. So, this article suggests that moderate intensity cardiovascular activity is cardioprotective, but there's also article where it gives that HIT programs might lead to beneficial effects on prognostic factors like peak oxygen uptake, ventricular function, and endothelial function, as well as improving cardiovascular quality of life. And this article is also from the Journal of Sports Medicine.
Is it feasible for IoT dissection? That's the question. Because high intensity interval training, definitely
so that is why we would anyways suggest a moderate intensity cardiovascular activity. This is specific to aortic dissection, which is cardioprotective. And other activity guidelines like Northwestern guidelines suggest can be started again, as I have mentioned, that walking and proper activities can be started.
What do you mean by moderate activity?
So, ma'am, the activities again include strain with the METs of 4 to 8. What they say. Hello.
Is it 3 to 6 or 4 to 8?
Hello.
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 Yes, Aishwarya, we can.
Yeah, it's audible.
Yeah, you're audible.
Ma'am is saying, is it 3 to 6 or 4 to 8?
Sorry, ma'am. 3 to 6. I'm sorry. So sorry. 4 to 8. 3 to 6.
So how do you decide this?
With respect to?
Yeah. Under ideal conditions, how will you decide?
How do you prescribe intensity, ma'am? Then to ask.
Okay. So moderate intensity can be like brisk walking, which would again depend upon the speed. But generally, there are other equations which calculate the metabolic equivalent minutes. The time spent on that can be more better in calculating the physical activity, which is more feasible than actually calculating the metabolic equivalents in specific.
What about exercise testing for aortic dissection patients?
Exercise testing can be done post. So you're talking about submaximal exercise testing, right?
Yeah, of course.
So,
submaximal or maximal.
6
symptom graded it is, na?
Yeah. So, sorry.
Symptom based.
Yes. So that was anyway. The 6 minute was done, and eventually a graded exercise testing can be started for the patient in later parts of phase 2, where we can actually get how much VO2 max or the metabolic balance are being tested.
You can basically go with 6-minute walk test, and you can have the maximum heart rate which is attained during 6-minute walk test, and
Yes.
from that you can have 50 to 60% of HRR, and you can prescribe exercise based on that with
Correct.
moderate intensity.
Correct.
That is one feasible thing you can do.
Hmm.
And again, the blunting response you have to keep in
The
mind
beta
always.
blockers.
Yes. So what are the supplements he's getting apart from the drugs you're saying?
So he's having a multivitamin, which is A to Z tablet, and he's getting vitamin C.
So when is the right time to get back to his activities like cricket, everything? When do you
So,
suggest for this patient?
as I said, cricket, I would advise against it since the contact sport and increased chances. But other than that, the guy.
Because he's just 28, we can't restrict him not doing any kind of
Yes.
sport
So
activity.
usually, like tennis, like which is and other things can be started post 6 weeks according to the guidelines.
Tennis can be started. There are
Yes.
many-
Ma'am, yes, Northwestern guidelines, they suggest tennis, but again, not doubles, where, the chances of having that physical contact and injuries is lesser. We can start. So, bicycling, light jogging, and things can be started. Swimming can be started post 4 weeks. It's a safe activity post the sternal healing.
What is the prevalence of aortic dissection?
Prevalence of aortic dissection.
Such patients, how many patients do you get like this as compared to other heart problems?
So currently in my term, I have just seen 2. One was this one, the other was the older one.
So it
But
is nice that you have selected such a patient, because these patients are not that easily, not very frequently seen. No?
yes, ma'am.
It is
This
nice.
side of patients comes at emergency purpose, like they come with like life-threatening condition. It's a life-threatening condition for them. An emergency surgery has to be done immediately, otherwise they have to be falling down.
Surprisingly, this patient had absolutely no symptoms to begin with.
Yeah,
It
exactly.
was
Yes.
just his
Really surprising.
regular checkup.
Patient was lucky.
Yes.
Really lucky. Yes. But I'm surprised that even after the detection, he was not, his activities were not restricted. He was
Yes.
Exactly. I was wondering that,
like
and
that.
after the detection, also 4-5
Yeah,
months
he remained
or maybe
careful.
3 months, he was not considered for.
No, surgery, they said that immediate surgery is not necessary, but then activities also were not restricted.
So
That is,
no, I asked him if doctor had suggested it against any activities, but he said no. The doctor said he can continue with the activities that he had going on.
so he played cricket and things like that, I think.
Yes.
You
He
mentioned
played cricket thrice, 3 to 4 times a week, and swimming 2 to 3 times a week.
He's lucky that he survived.
Exactly. I mean, now he would be feeling the surgery is restricting him more than the diagnosis.
Yeah.
And I think, ma'am, this is where I think we as SOCVPR, it is helping us understand what is happening in the country, because this is somebody who's come from Odisha. And I think if we have members there and, if we can map them, we'll know whom to refer to, because as we said, we lost him to follow up. Like we tried convincing even for tele and all, but they don't really follow up. It's difficult to convince them, but if we give like him a local address, that would really help, more chances that he would reach out to them, somebody locally, uh, then, to keep in touch with us. So that's why I think we as a platform would, that's what we are trying to do here, reach out to as many
That
patients as possible. That is there.
that's our vision. Huh?
Yes. Okay, thank you everyone. Rachna ma'am, I would like you to please give the vote of thanks.
Just before that, I just would like to appreciate Aishwarya. She's really made an elaborate presentation. Though
Thank
there
you.
are some things which were missing for me, but that's okay. But overall, it was quite an elaborate thing with all the details that she has put in. So I just congratulate her for her effort. Yes.
Thank you so
And
much,
I
ma'am.
assume Poonam must have been guiding her in that. So
Throughout,
congratulations to
start to
you.
end.
Thank you, ma'am.
It
Okay.
was a difficult case. Yes.
Now I have an idea. I'm going to make her wear a chest binder and experience how chest expansion happens, so she will know whether it restricts or it doesn't restrict. I
That
think that is an idea that I've got from here, that I will make all of them wear the chest binder and do breathing exercises, so they'll understand how it feels.
there was a study done, and it shows that it does not
It
restrict.
doesn't. Yes, even I.
It
But
has to
yeah,
be
I
done
think I need to make them do
with
it.
expansion, na? So they don't know usually, because it is already there, na? Tight.
Okay.
They don't know how to do it. So it you take a full deep
Deeper,
inspiration,
yeah.
then it's tight, right?
Yes.
So there's no such thing as you loosen it later on and for some activities. It is not, right?
Okay, ma'am. I'll keep that in mind.
I would like
Okay.
everyone to please put on their cameras so we can take a group picture, please.
Thank you. Nice. मेरा कैमरा ही ऑन नहीं हो रहा है
And please fill up the feedback form which is shared in the chat. It will really help us, improve on our content and know more of our events. So it is very, very important that we get your feedback.
So, shall I start, Poonam?
Yes, ma'am.
Yeah. So, I hope you all enjoyed this. It was a very interactive session, and we look forward to many more such. But you will have to reach out to us if anyone wants to present in the future and if you want such more programs. So we would be very happy if you could just send a mail, whichever college is interested. This is for all us to learn and to have more. We are very lucky. We have seniors who are willing to give their time to us and to guide us and to mentor us. I'd like to give the vote of thanks. I'd like to thank all our three esteemed judges. It's a Sunday, and I know all of us have something or the other. It's one for the family. Yet they have managed to take time out for this. So I'm extremely happy and grateful to have all three of them, Anjali ma'am, uh, Anuprita ma'am, and Hetal ma'am. Thank you very much for making this a successful event. To Aishwarya for being courageous enough to present in front of so many people. So it was but it's an experience that you share, and also all the participants who are there in this whole for your active participation has really made this more interesting. I'd also like to thank Maria ma'am for giving us the freedom to and to be able to organize and to give us her inputs in such events. Thank you, Manisha. As always, you're the pillar behind all of this, and Poonam, all your hard work has really made this whole thing a big success. I really am very thankful, and please, again, anyone who's interested in such events, who wishes to present, please do mail us at Society of CVPR, or you can even reach out to me at Rachna Arora at TNMC Nair. So anytime whoever is interested, see, it's an experience to share and to learn in front of so many people. You get different aspects, and every time you will learn something new, something different. And always learning is never, there's no end to learning. With everything, you will always continuously learn. Okay. So with this, I really I'm really happy that you all could all come today and be part of this.
Thank you very much.
Poonam.
Thank you.
Yeah. I
Congratulations.
hope you also enjoyed, madam.
Yes, yes. Every time it is a learning experience, you know.
Yeah, with
Every
every,
case is different, every case is new.
yes,
Mhm.
every time there's something new to learn.
Need to learn,
No?
yes.
Yeah, yeah.
Yeah. I also thanks SOCVPR to make me judge for this very unique case. It is not very common case. So it's good for everyone to learn from this case. And Aishwarya has done a good job for this. Thank you. Thank you.
Thank you.
Thank you.